Coxy grows in almost anything. So getting a media is not the question. We've got positive cultures on routine blood media. The important thing to remember, it takes a minimum of 2 days, but it can take 4 to 5 or 6 days. Most cultures are only kept for 48 hours, 3 days. So most routine cultures will not pick up Coxy. That's why you have to order fungal cultures to make sure that you look for Coxy and pick up those organisms. So the incubation time is what's really important, I think, in this term. So again, when you think of Coxy cultures, ask for fungal cultures. Another thing, it loves Legionella media. And we do a lot of Legionella cultures, and we actually have picked up quite a bit of Coxy and Legionella cultures. Funny, when we call the clinician and say, we've got Coxy, he said, I didn't ask for fungal cultures. Sorry, we can take that back if you want to. It's most technologists in Arizona recognize Coxy because they've seen it so many times. And early on, it's actually very difficult to tell. You could this is Legionella media up on top here, BCOA, and you can see a little light growth here. This is all garbage, but that's just a little white growth here. As it continues to grow, it becomes fluffy, and even fluffier here, and within 2 weeks, it's so fluffy, if that plate would be opened up, you'd kill everybody in the lab, because you'd have millions of arthrochonidia flying in the lab. So we're very, very careful. Dr. Impel says, let us know when you think of Coxy. Well, we don't wait for that. We consider every culture as possible Coxy, because you don't know what you're dealing with either most of the time. We've actually had one bad exposure that we had to put the patient on therapy. It was a urine culture submitted to us from another lab for diagnostics, and it was sealed and everything. We thought it was sealed. She was taken to move it into a hood. The seal had broken. The plate flipped open right in front of her. I'm sure she was already, that's another reason for doing a skin test. It would have been nice to do a skin test on her immediately and see how she had Coxy before. Because we didn't know, we had to put her on therapy for a period of time, usually a couple of months. And fluconazole is not nice. They tell me that it's terrible, actually. You should try it yourself sometimes. It causes tummy aches from what they told me. Lab diagnosis, identification is quite easy. Microscopic morphology with spherules, that's Coxy. So when we see histopathology is positive, we get growth, we don't go further to identify it. We say presumptive Coxy because you already have the diagnosis. On the other hand, if we need to identify it, we go to, right now, all these other things are old. Mouse inoculations, converse media for conversion, and genetic probes are old. Trying to find that, oh, there it is. Genetic probes now being used to get the RNA of the organism and identify it as Coxy. We can't separate Posadaceae from Imidis, but we can call it Coxy species. And that's all you really need right at this point. I'll finish up with the hardest part, that's the serology. We've got IgG and IgM. IgM becomes measurable earlier on, but look at the time frame. It's the first week about 50% of patients, and third week about 90% of patients. So it's still a very variable amount of time. Somebody comes in with community-acquired pneumonias, usually in the first week of infection. You may have a negative serology at that point. The IgG, or what we also call the complement-fixing antibody, becomes measurable between the 2nd and 28th week. That's an awful long time frame. May remain positive for several months, but usually is related to disease activity. A lot of people also don't relate that IgG and IgM are indication of infection. They're not protective. So the higher the titer, especially of IgG, the more problematic the case is. The patient is actually having a great amount of activity of Coxy. So it's not protective. It really does give you indication of the amount of disease the patient has, of what is happening. This is a good indication here. This is CMI, cell-mediated immunity. So as you have good cell-mediated immunity, you usually are able to localize the disease. As your cell-mediated immunity wanes or becomes poorer, that's when you start to actually enhance the the ability to disseminate the disease. Serum antibody over here, as that starts to increase, the better the chance you have of actually having dissemination of the, that's why we say follow titers. We're talking about complement-fixing titers or immunodiffusion titers that actually follow complement-fixing antibody, or IgG. This is an old picture here. As you can see, the first one, very first one here, the line is actually skin testing, and it's the first thing to turn positive. IgM is the second thing to turn positive, and then IgG comes up after that. So you kind of get a feel for how these serologies mount up and how they disappear again. So cell-mediated immunity, skin testing with virulence, coccidioitin is no longer available, but may be available in the future, as mentioned. Humoral antibody indicates level of activity and is not in itself protective at all. Two precipitants were the old IgMs. Very few people do that anymore. Mostly we now use EIAs, IgM and IgGs, and immunodiffusions, IgM and IgGs, with complement fixation actually used to follow titers. Complement fixation should not be used as a diagnostic test by itself, okay, because it is the least sensitive of all of the other ones. But it can be very useful to follow titers, especially if done consecutively. Serology, humoral antibodies, I'm not going to talk too much here because I want to finish up quickly. EIAs, IgM, and IgGs, most sensitive, but that's controversy. You heard earlier today, the state counts any IgM positive as being a positive infection. I'm not sure that's always correct. It could be somebody that's actually has a minor disease and becomes asymptomatic very quickly, and I'm not sure about that, but we've had a lot of patients with IgMs that did not seem to have cocci. Immunodiffusion, that's more specific because what you're getting a line of identity. What happens is we put the, I'll use this site here, the antigen is put in the middle and the patient's sera are put in the outside wells with diffusion going on. So well 1 and 4 are normally the controls with known positive cases, and then the patients go into wells 2, 3, 6, and 5. You can see 2 and 3 are negative, there's no line, whereas 5 and 6 not only have a line, but the line connect with the lines from the known positive patients. That's called a line of identity. Sometimes you see lines but they don't meet with the other line. Those are lines of non-identity. We cannot call those as positives. Complement fixation test also is useful, as I mentioned, and not most labs, but some labs perform that. They're very useful to follow titers, especially if you got somebody that's progressively getting worse or is not doing well. And that's when you would use that component. Quickly, EIA IgGs. In one study, this was looking only at positive, culture-positive sera. EIA was most positive, was most sensitive with 79%, EIA IgM was 63%, EIA combined 83%, ID 71, and CF 64. What this study did not do is look at the false positives. They did not look at culture negatives and see how many of those has positive serology. So this is just looking at positive cultures. A study we did very quickly because we wanted to use EIAs as a screening test. And the reason we want to do that is we can do that one day. If it's negative, it goes out the door. If it's positive, however, then we would set up immunodiffusions to see whether or not we would get the line of identity. If we were to do immunodiffusions alone, a negative immunodiffusion takes 5 days. You have to wait that long to call it negative. A positive can become positive faster, but a negative has to wait for at least 4 to 5 days, depending on what kit you're using. So we used this test here, and we found 50 patients. All of them were negative by EIAs. They were all negative by immunodiffusion. So we felt comfortable using the EIAs, a rapid screening test, getting it out of the door. Dr. Blair did a study where she found 405 patients. There were no false positive IgMs in her study. So they felt very strongly that IgMs were very, very specific. Dr. Kubersky, on the other hand, did the same thing. He did 17 patients, and he followed these patients both clinically as well as by looking at their charts. And what they found was that when the IgM was positive alone, they had a very high rate of what they felt was false positives. When both IgG and IgM were positive, they had only 20% false positives, they felt. So when you see an IgG, IgM, EIA, both positive, you have a much better chance of that patient really having significant, he might have cocci, but maybe an insignificant cocci, but significant cocci. This is just another presentation. I'm not going to spend much time here of his patients that he followed up. And this was actually retested by a referee lab, and the referee lab was Dr. Papagiannis' lab, which could not confirm the IgM, IgG at that point. So problems with serological diagnosis. First of all, serologies are always prone to false positives and false negatives. You know, the one thing I want you to understand is serologies are not perfect. Especially early on and later on. And so they should not be used alone as an indication of anything except as you have to look at your patient, look at the clinical circumstances, and then use that serology to confirm or refute your clinical decision making. There's lab-to-lab variability. There's lot-to-lot variability. There's discrepancy between test systems, reagents, and automation. So all of these things play a role. So I feel very uncomfortable saying one serology is positive. We had a patient with hepatitis, for example, or was diagnosed with hepatitis because the IgM was positive. Not once, repeatedly positive. And so that poor patient was told that she had hepatitis. There's a small percent of patients that have biological false positive IgMs who do not have hepatitis. So you have to understand the background of these things when you make your decisions on some of these patients.